So this patient, we're going to discuss sepsis. The nurses, part of their documentation is something called the EWS, like an early warning score. And what that factors in is, when the PCTs and nurses are taking vitals, any changes in their vitals, as indicated with what they call search criteria. So that would be either there's hypothermia or hyperthermia. Hypothermia would be a temperature of less than 96.8 degrees. Hyperthermia would be greater than 100.9 degrees. Heart rate greater than 90, so they start getting like very, what they call tachycardic. This is outside of patients that have like chronic AFib. Increased respiratory rate, so greater than 20. You're noticing that they're breathing, and it's also becoming maybe a little bit more labored, and they're breathing very fast. There's also part of the EWS will ask about changes in implementation. Sometimes that can be an early indicator of infection. You'll see that a lot of times with someone that ends up developing a urinary tract infection. Sometimes, when it's like the patient's on the floor, you may notice like a change from their baseline as far as implementation goes. Excuse me. Other factors we look at as far as search criteria is also labs. So it would be either white blood cell count. Is it dropping? Is it less than 4 or greater than 12? Sometimes in our oncology population, especially in our neutropenic patients, we'll notice that the white blood cell count may be very low. So there's that's the population alone that's more prone to developing sepsis. And sepsis, like most of the times, the origin of infection can come from either the lungs, it could come from the gut, it could come from the skin, or it could come from the urinary tract. So that's why it's very important that we get those Foley catheters out as soon as possible. And as discussed, like in a lot of in-services I do, I'm trying to have midlines removed, or central lines, and the Foley catheters as soon as possible, because again, that's a source of can create a source of infection that can lead to sepsis. So our source criteria is discussed here. So if the patient ends up meeting 2 of the source criteria, as I just discussed with the labs, the white blood cell count, either being low or elevated, and then those changes in their vital signs, as well as their bands as well. So we want to act fast. Early intervention is always the best. So if we suspect that a patient might be septic, then at that point, don't hesitate with calling a rapid response. So then at that point, then we would have the hospitalist come. Usually you have the nursing supervisor, and then the whole team comes in from the unit to help assess the patient. And then there's also a bundle then that we initiate. Once we move on to more of severe sepsis, then you can see even organ dysfunction at that point. So that would be reflected in the lab work. That's why a lot of times we're drawing labs at that point. So we'll end up establishing an IV line if the patient doesn't already have one, so we can initiate fluid boluses, and then also draw labs, because we're looking at, outside of like I was saying, their vitals and their white blood cell count, you're also looking to see, is there organ dysfunction? Is there creatinine? Is there any changes in that which could indicate kidney dysfunction? Bilirubin and platelets and INR, that can also indicate issues with their liver, coagulation and bilirubin are all something that is impacted by the liver dysfunction. Also acute respiratory failure. So you'll see sometimes a respiratory therapist, they usually show up to all our rapids. They may start up the patient on BiPAP. If this patient is in severe sepsis or severe septic shock, at that point, a lot of times they end up getting intubated. So that's why I'm saying early intervention is so important. So if we have to initiate that rapid response because we see changes from their baseline, and it's indicating that they're becoming septic, then we need to act fast. So part of the bundles, as I was saying. So we also, outside of drawing that lab work, we also want to draw lactic acid, because that can be an indicator of infection as well. Drawing blood cultures as well before we initiate antibiotics. So a lot of times you'll see an order go in for antibiotics, but we want to make sure we get that lab work done too. We can a lot of times at the same time as inserting an IV catheter, we can, get the labs at the same point, but we have to remember that with blood cultures, we also have to wait 15 minutes and then draw a second set. Is drawn in 2 sets, aerobic and anaerobic. And so it's drawn from one site, and then we have to wait 15 minutes and then draw from another site as well. And then make sure that we indicate that on the blood culture, the bottles itself. With the sites that they're drawn from, the time, your initials, and the date. Okay. So if the lactic acid is greater than 2, it auto generates then a 6-hour bundle. So that's a repeat lactic acid. The lab it'll be auto generated. And then we will also document 2 blood pressures in the hour after we start up the fluid boluses. So if their systolic blood pressure is less than 90, we want to get those fluid boluses going as soon as possible. That's why I support that we establish a good IV line. All right, and so the lactic acid, so this is at this point, we're moving down and we're assessing for septic shock. Okay, so lactic that's greater than 4, we're looking at maybe severe sepsis at that point. And as also indicating organ dysfunction. So also if we also have 2 hypotensive readings, 1 hour following the conclusion of the fluid boluses. And so then it says here again, you must begin within 3 hours. This is very important. Of course, we want to initiate it as soon as possible. I don't like they're usually that 3-hour being used, but window being used, but for the 3-hour bundle and then 6-hour bundle. 3-hour bundle is usually we're initiating it at the same time as the rapid cold at the same moment at the bedside. So I have handouts here that will explain more, in more detail, early sepsis, severe sepsis, and then septic shock, and the differences between each one of them, and identification as well. Is there any questions in particular about sepsis that you have? No.